Good morning. I will be picking up on some of the same points we've already heard from Dr. Sherman and Dr. Freeman, with more emphasis on the thyroglobulin and how we use it. My disclosures there, and focusing again on recommendation 50 of the ATA guidelines, clearly states with a strong recommendation to evaluate the patient postoperatively and take into account the clinical situation before making decisions on management. And key in that is the postoperative thyroglobulin, whether a suppressed level on thyroxine or a TSH stimulated level. Another strong recommendation. And there are data that support that this study that showed when the TG is less than 1, it's associated with an excellent outcome. This study that showed the disappearance of TG with time after surgery has a high positive predictive value for recurrence. The thyroglobulin clearly correlates with whether there is residual or recurrent disease or progression, and can predict that. This study by Kim showing you on the left when the thyroglobulins are less than 2, in the middle between 2 and 10, and on the right greater than 10. And complete remission in the aqua bar you see reducing as the thyroglobulin is higher, and recurrence rising. Other studies that show that same prognostic utility, and to remind us that even when it's undetectable, there can still be recurrence. It's sort of that positive data is stronger than negative data. So a measurable TG is a stronger indication for recurrence than an undetectable TG is a predictor for cure. This study of about 4,000 patients again showed that high negative predictive value for TG. So what factors are important to predict how the patient will turn out? How much thyroid tissue was left behind? That will influence the TG. How high the TSH level at the time of evaluation? Is it fully suppressed or not? How good is the TG assay? What is the functional sensitivity? Is it 0.1, 0.05, 0.5, or 1? And as you read the literature over the last 5 or 10 years, you'll see data that employed TG assays with a wide variety of functional sensitivities. And the time, when do you measure the TG? Typically, the guidelines relate to measuring TG at about the time that you would be anticipating radioiodine ablation. So 4 to 6 weeks after surgery. With thyroglobulin assays, it's well accepted. They should use the same international standard. And as you follow a patient, you should be using the same laboratory that employs the same assay. You should always measure antithyroglobulin antibodies at the same time you measure TG. And if that surgical specimen demonstrated Hashimoto's disease, you should expect that TG antibodies will be positive. And if they're negative, you should suspect the assay. And the TG may be falsely low because of interference of those antibodies, and that would be a good reason to try an assay in a different laboratory. The question I posed here, whether stimulated thyroglobulin before ablation might be useful to predict recurrence, and I cite a couple of studies here looking at how successful ablation will be. And if the stimulated thyroglobulin is greater than 6, that has been associated with failure of ablation. Whether the ablation was done with 30 millicuries, as in the first study cited there, or even with 100 millicuries. And if that TG is stimulated and is greater than 6, in the first study, there's a 5-fold risk of failure with a 30 millicurie standard ablation. This old study by Klus and Mazafari actually showed the same thing quite a long time ago. 107 patients, and their cutoff for thyroglobulin was 2 nanograms. And if the stimulated TG was less than 0.5, that indicated a good outcome and probably no need for intensive follow-up, whereas those patients who stimulated higher had the higher likelihood of risk of recurrence. So a postoperative TG is most helpful to identify those patients who will benefit from ablation. Again, positive trumping negative, measurable thyroglobulin. So you would ablate even a low-risk patient who you might not consider ablating, but if the TG is between 5 and 10, that is going to connote a higher likelihood of recurrence and therefore an indication for ablation. So what is that cutoff? What is the level of TG postoperatively that will help you decide whether you use radioiodine or not? And in one study I have cited here, they talked about a cutoff of 5, in another one a cutoff of 2, and we've reviewed the data from Toronto. What did the guidelines say in recommendation 50? We don't know. The optimal cutoff, whether we're talking about a suppressed level or a stimulated level, is not known. So no recommendation was given on the basis of insufficient evidence. So during our follow-up, there are studies that looked at what is the most sensitive method we can employ to find recurrence. TG, suppressed, stimulated, a stimulated scan, or ultrasound, and looking at just the baseline TG, you can see that the false negatives are significant. Just the scan, the false negatives, also significant, but with a stimulated TG, no false negatives, and a low false positive rate, 100% sensitivity, 100% negative predictive value. So this led to a number of studies. This is just that same data, and you can see the highest yield was the combination of thyroglobulin with ultrasound at almost 100%, shown here graphically in the last bar, 99.5% negative predictive value with that combination. So in low-risk patients, again, guideline 63, a strong recommendation to measure in follow-up, and repeat stimulation testing not recommended in the guidelines in low-risk patients in whom there is a documented excellent response. But you should consider stimulated TG testing if it's an indeterminate response or there is evidence of disease biochemically or structurally. So how do we follow these patients? We found that a second or third stimulation test increased the yield And if we added ultrasound to that, it had 100% negative predictive value and sensitivity. So frequency of follow-up is adjusted to your risk estimate. We do a stimulated TG 1 year after therapy, and if there's no response, we still consider one additional stimulation test 3 years later, coupled with ultrasound, to get us that 100% negative predictive value. So our follow-up management in general includes physical exam, baseline blood levels, periodic ultrasound, a stimulated TG at 1 year, highly selective use of scanning to identify suspected disease, the same with CT and PET-CT. In the longer-term follow-up, say out at a year, we would do a TSH-stimulated TG, no increase, repeated 1 time, 2 or 3 years later with ultrasound. If there is an increase on stimulation, then of course we look for the disease with imaging. And then the long-term follow-up up to 20 years, we all see occasional patients that will recur after 20 years, and perhaps we were using insensitive TG assays to follow those patients, or whatever the reason, there is good support for continuing to follow an annual TG, perhaps an ultrasound every 2 or 3 years. We're seeing those patients anyway to measure their TSHs and free T4s to adjust their thyroxine dosage, so why not also get a TG at the same time?